Welcome to lecture 2 of this series. These lectures accompany my book, Manual of Fluid, Electrolyte, and Acid-Based Disorders, a Pathophysiologic Approach to Common Clinical Problems. I am Dr. Mohammad Tinawi, and you can find more information about the book in the description. This is the book. We are still on Chapter 1, Disorders of Water Balance, Hyponatremia and Hypernatremia, and this is Part 2. I will start with a very important concept, total body water, or TBW. We really have to know this very well. Approximately 60% of lean body weight in men and 50% of lean body weight in women is water. Now, the water is either inside the cells, intracellular, or outside the cells, extracellular. The extracellular fluid is about a third of total body water, while the intracellular fluid is 2/3 of total body water. So most of the water in the body is inside the cells. Now, when we look at the extracellular fluid, now the 1/3, about a fourth of that is intravascular. This is the plasma water. And 3/4 is the interstitium. This is the space in between the cells. So again, 50% of lean body weight in women, 60% of lean body weight in men is water, 2/3 is inside the cells, ICF, intracellular fluid, 1/3 is extracellular, ECF. Of the extracellular, 1/4 is plasma water, and 3/4 are in the interstitium. Now let's take the example of a woman whose lean body weight is 60 kilograms. Total body water will be 1/2 of that, or 30 liters. The extracellular fluid will be 1/3 of the 30 liters, or 10 liters. Plasma water is 1/4 of the extracellular fluid, or 2.5 liters. Now the intracellular fluid is 2/3 of total body water. That will give us 20 liters. For a man whose lean body weight is 70 kilograms, we have 42 liters of total body water. 70 times 0.6 equals 42 liters. Now, 1/3 will be in the extracellular space or compartment, which is 14 liters. Plasma water is 1/4 of that, or 3.5 liters, while 28 liters will be in the intracellular compartment inside the cells, 28 liters. Now, hyponatremia is usually due to an increase in extracellular water rather than a decrease in extracellular sodium. Now, we spent pretty much all of the first lecture talking about that concept, and I promised that I will continue to repeat it. So again, never think of hyponatremia as just too little sodium. It's a disorder of water balance. So usually we have an excess water relative to sodium. Now, let's take some examples. Someone with congestive heart failure. Someone with congestive heart failure will have extra water. Total body water is increased. Sodium is increased too, but the increase in water is more than the sodium. So you can see that there is an imbalance. Now, someone with vomiting or diarrhea has decreased total body water and decreased sodium, but the decrease in sodium is more. So again, imbalance. So both went down, but the sodium went down more than the water. So in vomiting and diarrhea, we got what? Hyponatremia. Now, if we take someone with the syndrome of inappropriate secretion of ADH, here, total body water is really unchanged. There's just low sodium, okay? So total body water can be increased, decreased, or unchanged, and the reason for the hyponatremia is this imbalance between water and sodium. Generally speaking, there is more water than sodium. This is why sodium drops. And more on these disorders will be discussed later. It is important to know that water moves freely between the intracellular and the extracellular spaces. Therefore, the osmolality in the extracellular space is exactly the same like in the intracellular space. Because if something goes up, sodium, for example, or glucose, on one side, water will shift, and then osmolality will be the same. Now, serum sodium then is determined by this balance between intake and excretion. For example, under normal circumstances, if we get a normal person and if that person increases his salt intake, what's going to happen? The person will drink more water, and then the salt will be excreted and serum sodium will be unchanged. Now, on the other hand, let's take another person. Let's say that she decreased her salt intake severely. The kidneys will preserve the salt and the sodium will remain unchanged. Now, in hyponatremia, there's this imbalance between sodium and water, or in other words, the water that is consumed is improperly excreted. Normally, if one increases his water intake, the excretion should increase and everything is balanced again. That doesn't happen, say, in someone with SIADH or someone with congestive heart failure. Again, think of this imbalance. Now, what about antidiuretic hormone? Now, if you want to remember one word about the pathogenesis of hyponatremia, this is it. Vasopressin or antidiuretic hormone or ADH is the same thing. So we're going to say ADH or vasopressin or antidiuretic hormone. This is the main hormone responsible for maintaining water and sodium balance. So remember that, never forget it. Now, ADH comes from the posterior pituitary, and its secretion in the body is stimulated by one of two mechanisms. We have either osmotic stimulation or non-osmotic stimulation. Osmotic stimulation is when the osmolality of the plasma increases, so ADH goes up. Now, non-osmotic stimulation is when blood volume decreases, what we call the effective arterial circulatory volume, how much blood is in the arteries. When that decreases, say because of hemorrhage, shock, then ADH will also increase. This is non-osmotic stimulation because osmolality really didn't change. It's the blood volume that is decreased, or at least the kidneys are sensing that the blood volume is decreased. And this is why in septic shock after giving norepinephrine, sometimes we use vasopressin. And in that case, you're really using it not to stimulate the kidneys to preserve water, it's actually for its vasoconstrictor effect. So here, let's focus for a second on the osmotic stimulation. If serum osmolality increases by even 1%, ADH or vasopressin stimulation increases. What's going to happen? Water absorption from the collecting tubules in the kidney will increase, and that water will dilute out the sodium, and then serum osmolality is restored to the normal range, and then that excess water will come out in the urine. For example, let's say that someone eats a bag of potato chips. The sodium will be absorbed, and the osmolality in the serum will increase because of the increased sodium. Now, what's going to happen? The person is going to feel thirsty and drink more water. The ADH will be excreted because of increased osmolality. So more water will be absorbed in the collecting tubules, and then that excess salt and water will go out in the urine, and then serum sodium is restored to normal, and plasma osmolality will be restored to normal. This is why in normal individuals, irrespective of their intake, you don't see much variation in their sodium concentration or serum osmolality because of these wonderful mechanisms that we have. Now, antidiuretic hormone excretion, and now here we're talking about the mechanisms of hyponatremia. ADH secretion will lead to increased absorption of water in the collecting tubules, and that can be either compensatory or appropriate, like in patients with heart failure, liver cirrhosis, dehydration, because you need that excess volume to improve the renal perfusion, cardiac output, etc. Or it can be completely inappropriate, no good reason for it, like in patients with the inappropriate secretion of antidiuretic hormone or SIADH. We'll discuss that later. And actually this like appropriate, inappropriate, this is really like my wording. This is how I would like to think about it. Whenever I see someone with hyponatremia, I know that the antidiuretic hormone secretion has increased their stimulation, and I think, what is it exactly? Is it appropriate? Is it expected, like heart failure, liver cirrhosis, dehydration, or is it inappropriate, like in SIADH? It's just, it helps to know the physiology. Now, last lecture I said that hyponatremia can be hypotonic, which is by far the most common, can be hypertonic, like we said, someone with hyperglycemia, you get that shift of water into the plasma water from inside the cells, not very common, but we see it. And isotonic hyponatremia, I mentioned that for the sake of completion, and I said it was rare. So our focus for the rest of the lectures is going to be on hypotonic hyponatremia. In other words, sodium is low, and you measure plasma osmolality, and it is low as well. Now here, when you assess the patient, you assess the volume of the patient can either be dehydrated, meaning hypovolemia, so low blood pressure, orthostasis, poor skin turgor, thirst, etc., or the patient is euvolemic, or the patient is hypervolemic. Okay, they have excess water. Now, hyponatremia with hypovolemia, we see that all the time. Can be due to renal causes, diuretics. And this is so common. Patients come dehydrated because of diuretics and they're hyponatremic and their volume status is low, meaning they're dehydrated. Extrarenal causes, GI causes, also very common, vomiting, diarrhea. Now, when the patient is euvolemic, it's usually syndrome of inappropriate secretion of ADH. So SIADH is by definition euvolemic hyponatremia. You cannot really diagnose SIADH if the person is dehydrated or if they're fluid overloaded. So it's by definition, this is by definition hyponatremia with euvolemia. Now, hypothyroidism and adrenal insufficiency can manifest exactly like SIADH, so we need to rule that out before ascertaining a diagnosis of SIADH, and more on that later. Now, hyponatremia with hypervolemia, also very important. You see that in patients with heart failure, liver cirrhosis, the nephrotic syndrome, acute kidney injury, chronic kidney disease, and a very, very important category is low intake of solutes. More on that in a minute. Diuretics. Thiazide diuretics are a very common and important cause of hyponatremia, especially in the elderly. When you start a thiazide, hydrochlorothiazide, chlorothalidone, indapamide, you really have to check serum sodium in like a week, and then in a month, and every 3 months. This reaction, this hyponatremia, is idiosyncratic. You cannot predict who will get it, but it's more common in the elderly. If it happens, the patient is not a candidate for further treatment with thiazides. Loop diuretics, on the other hand, tend to cause hypernatremia. Why is that? With thiazide diuretics, there's loss of sodium and water. With loop diuretics, also there's loss of sodium and water. But with thiazides, you lose more sodium than water, so you get hyponatremia. With loop diuretics, like furosemide, torsemide, and bumetanide, you lose more water than sodium, so you get hypernatremia. Again, it's a matter of balance between the sodium and water. And I can say that also it depends on what you're replacing with. So if you get someone on a loop diuretic and you start giving them hypotonic fluids like D5W, well, they're going to become hyponatremic. So you have to think of what's coming in and what's going out. I have to say a word about cerebral salt wasting. It's really rare, but sometimes it gets confused with SIADH. Patients with cerebral salt wasting, they come in usually several days after a subarachnoid hemorrhage. They're dehydrated, they have low blood pressure, they have orthostatic hypotension. Their urine osmolality is 100 to 300. Urine sodium is over 40, but sometimes can be really high. It can be 150, 200. If you see a case ever, you won't forget it. And these patients, you have to give them saline and lots of it. Sometimes you need to give 3%. Most patients with subarachnoid hemorrhage or cerebrovascular accidents, actually they have SIADH and not cerebral salt wasting. But it is important to know that this disorder does exist. What about hypervolemic hyponatremia? Here we have signs of volume overload, edema, ascites like patients with heart failure, liver cirrhosis. Here the effective arterial circulatory blood volume, what's inside the artery, is decreased. The kidneys get a sense, oh, we're not getting enough of the cardiac output. The kidneys are very greedy. They get about 20-25% of cardiac output, and they don't want to give that up. So when they sense that they're not getting enough, like someone with heart failure or liver cirrhosis, what's going to happen? Signals are going to travel and ADH secretion is going to be increased, and then you get water retention. So with that, the kidneys are going to retain water and also retain sodium. So urine sodium will be low, but again, water retention is going to be more than sodium retention. So this is why you get hyponatremia. Like I said before, patients with liver cirrhosis and heart failure have excess sodium and excess water, but more water than sodium. You see the same thing in the nephrotic syndrome in patients with acute and chronic kidney disease. So this is a very common cause of hyponatremia. Now, what about hyponatremia in hospitalized patients? The most common cause of hyponatremia in hospitalized patients is administration of hypotonic fluids. This is erroneous. This is iatrogenic. So many times patients come into the hospital, sodium 134, 135, and they get 0.45 normal saline or D5W, and that causes hyponatremia. Post-operatively, especially in women, this is dangerous. There has been deaths due to severe hyponatremia. So, in hospitalized patients, unless the patient is hypernatremic, stick with normal saline, isotonic saline, or lactated ringer with something that is isotonic to the plasma. Do not give D5W or half normal saline unless there is a reason. What's the reason is? The reason is hypernatremia. Okay, so that should be clear, should be easy enough to do, and then we can avoid many, many complications and issues. What about patients with beer potomania? These patients who drink a lot of beer, beer is hypotonic, and same situation, patients with primary polydipsia. Usually these patients with primary polydipsia have psychiatric disorders. So these patients drink so much water, and that overwhelms the kidney's ability to excrete it. So they drink more than 10, 15 liters, so it has to be really excessive. I mean, a normal person may drink 2 to 3 liters a day, so they're drinking 5 times more than that. So the kidneys lowers the osmolality, lowers the urine osmolality more and more and more, but it cannot go lower than 50 to 100, then what's going to happen? Whatever is drunk after that is going to be retained. So urine osmolality in these patients is very low, and when you put them in the hospital, you have to be careful. You cannot just water restrict them immediately because they start to diurese, and you can really have rapid and dangerous correction of hyponatremia. And I will talk about that more when we talk about treatment. But these conditions have to be recognized. what about patients with low intake of solutes? Now, this is something textbooks don't talk about that very much, but we see it a lot in hospitalized patients. So you get someone who is elderly, their intake of solutes, meaning protein, sodium is low, but their fluid intake is high. So again, you get this imbalance. Some people call it tea and toast diet, and they present with hyponatremia because especially the elderly, they cannot lower their urine osmolality as much. So meaning after a certain point, whatever they're going to drink is going to be retained. So the solution to that is to do water restriction and to increase intake of nutritious food. They need the protein, they need the bread, they need the sodium. So this is very common in hospitalized patients, and you make the diagnosis. It's really a diagnosis of exclusion, and urine osmolality obviously will have to be low. And when you feed them properly, you can notice that urine osmolality has increased and the sodium started to get corrected. Now I'm going to stop here, and we'll see you in lecture 3.